The frontline therapy for patients in need of treatment with follicular lymphoma is an area of great contention. And I think we consider that chemotherapy with an anti-CD20 monoclonal antibody is the standard of care. And the chemotherapy backgrounds that we use may be bendamustine, CHOP chemotherapy, or CVP chemotherapy, which is very much loved in some territories. The choice of antibody is between rituximab and the third generation anti-CD20, which is obinutuzumab. An alternative approach is the use of rituximab with the immunomodulatory agent lenalidomide, which is being used in some circumstances. So the choice of CVP for this patient, to my mind, is an optimal choice. CVP chemotherapy is given as outpatient treatment on a 3-weekly basis. It's very well tolerated. We understand the toxicity profile for patients, and patients tolerate it well. If we use other chemotherapies, such as CHOP chemotherapy, we recognize that patients may have a greater risk of infective complications, and also, of course, they lose their hair, which obviously is one of the distressing side effects of chemotherapy. Bendamustine has become an important armamentarium for many investigators, for many physicians, and appears to perform well when compared with CHOP chemotherapy, but is without many of the acute side effects of CHOP chemotherapy. So patients don't lose their hair, they don't get neuropathies, and they have a very low incidence of febrile neutropenia. So we have a number of different choices. CVP for a patient who is 72, a patient who has comorbidities, in this case the patient has a degree of renal impairment, to my mind is a good approach for this individual. So we think about a lot of different clinical parameters when we're making our choices with follicular lymphoma. We're thinking about clearly patient-related factors. So with, thinking about comorbidity, we're thinking about disease-related factors. Some of the parameters we've spoken about already. We recognize that bulk of the disease also confers a somewhat worse prognosis in patients. So we're balancing these together. I always like to biopsy the largest lymph node because I'm always concerned about the risk of transformation in particularly bulky lymph nodes. And in this case, this demonstrated just grade 3A follicular lymphoma, but with no evidence of transformation. So therefore, I'm comfortable and confident in using CVP chemotherapy. If I was at all concerned about the risk of transformation, then I might try and use CHOP chemotherapy, but recognizing that there is a difference in toxicity and that this patient, for example, may not tolerate that quite so well. We already know that there's some comorbidity because they have a reduced renal impairment. As well as making a decision about the chemotherapy backbone, we also need to make a decision about which anti-CD20 monoclonal antibody we're going to use. So we've known for many years that adding rituximab, the anti-CD20 monoclonal antibody, to our chemotherapy in the frontline therapy of follicular lymphoma improves response rates, progression-free survival, and overall survival. Obinutuzumab is a third-generation anti-CD20 monoclonal antibody. It targets a slightly different epitope to rituximab on the CD20 molecule, and it has a different mechanism of action. It has an enhanced antibody-dependent cellular cytotoxicity effect and a greater direct cell kill than rituximab. So in the test tube, it's a much more effective antibody. So obinutuzumab has been shown in the Gallium phase 3 trial to be a more effective antibody than rituximab in terms of prolongation of progression-free survival. And for that reason, it's the ideal partner to give with your chemotherapy.